So, thank you all so much for joining. Happy Good Friday for those who celebrate. My name is Michael Kinnucan. I'm the Health Policy Director at the Fiscal Policy Institute. And today I'm going to give a very quick and somewhat informal presentation about a really critical issue that has emerged late in the state budget negotiations, which is the future of the New York Essential Plan and to what extent we can act to preserve coverage for those who are set to be kicked off the Essential Plan um, in July. So I'll be giving a fairly quick presentation, should be done talking in about half an hour about where those negotiations stand, what the background is, what the prospects are. And then I will take some questions and we'll wrap. Um, and for those of you who might be wondering, we will send out slides and a recording of this webinar following the meeting. So if you don't get everything the first time, you can feel free to rewatch. So with that said, I'm just going to share my screen. I have a very rough and ready presentation. Um, all right. Um, So longtime followers of my work at the Fiscal Policy Institute and of our public statements know we've been very focused on federal healthcare cuts to and how they'll impact New York coverage, and in particular on the Essential Plan. I'm going to just update where we are with the federal government. Um, and how that impacts the Essential Plan. I'm going to talk about some competing estimates that have been tossed back and forth in the press around how many people's coverage really is at risk. Then I'm going to essentially present a really fantastic proposal that emerged from the work of the Community Service Society and Make the Road about how to prevent coverage loss in the Essential Plan that's now embodied in a bill sponsored by Senator Rivera and Assemblymember Paulin that I really think should be our top priority for healthcare access in the budget. Talk about where we can find the money to fund that plan, and then take questions. So, just to reground ourselves in sort of where we're at in New York healthcare policy, New York has a long history of being a national leader in guaranteeing health insurance to low-income people. This federal cuts enacted by Congress last summer put that legacy at risk. We are facing a really, really dramatic loss in coverage due to those cuts starting this July. And this graph just sort of shows the scale of what we're looking at. We could increase our number of uninsured by over 1 million people in the next 2 years if the legislature doesn't act now to prevent those cuts. That would reverse virtually all of the progress we've made on this since the advent of the ACA. And so this is a really critical issue. Um, we're facing healthcare cuts from a number of sources. Essential Plan enrollees, around 450,000 of them are threatened with cuts. Medicaid work requirements could threaten the coverage of 800,000 more people. And then there are specific immigrant groups that had their healthcare cut back in by the federal government, including immigrants who are on the individual market and the DACA population. And between those two groups, that's about 36,000. So extremely concerning. I'm going to be focusing on the Essential Plan population, those 450,000 in this presentation, not because they're the most important, but because they're really, really urgent. people in this population have received letters already this week warning them that their coverage will end in July. So that's this July, not next July. It's 3 months away. So we'll be focused on that. Although in past work and future work, we'll be focused on other populations as well. Um, So just to update folks, I'm not going to go through the whole context of the essential plan because this is a technical briefing. It's, sort of aimed at policy obsessives like myself who follow this stuff. But you can go on the Fiscal Policy Institute website and get the full background on how the essential plan was cut by HR1 and how the state planned to respond. But the short version here is that because the federal government dramatically reduced funding for the essential plan, which covers 1.7 million New Yorkers earning up to 250% of the federal poverty line, because the federal cuts impacted that, the state announced a plan way back in September to reduce the threshold for eligibility for the essential plan from 250% to 200% of the federal poverty line. That proposal would protect everyone under 200% of the poverty line, including immigrants, US citizens, everyone who's on the essential plan now and earns less than 200%. But it would leave the people making over 200%, which is about 450,000 people, it would leave them without coverage and forced to seek other coverage. So that plan required federal approval, and there was some uncertainty about whether we would get that approval. But as of late March, we did get federal approval for this plan. So what that means is that the 1.3 million people who are on the essential plan and under 200% of poverty are protected, but the 450,000 people who are above 200% will lose coverage in July. There's been some pushback or question coming from the executive, from the governor's office and the Department of Budget about whether these folks who are about to lose essential plan coverage will become uninsured or whether they'll find some other source of coverage. So we've heard from the Department of Budget and also, unfortunately, from the Assembly Speaker's office that they think really of these 450,000 people, about 300,000 will find some other source of coverage. So that could be the individual market or employer-sponsored insurance. To me, this seems fanciful. I think a few of the 450,000 will find alternative sources of coverage, but the vast majority will become uninsured, and we have to sort of go in with open eyes as we consider this. And I'm going to talk about why it's unlikely that they'll find individual market coverage and unlikely that they'll find employer-sponsored coverage. So the individual market is unlikely to sort of pick up the slack from the essential plan. First of all, because about 20% of the impacted group actually aren't eligible for premium tax credits on the individual market. So what that means is, to get coverage there, they would need to pay $10,000 a year out of pocket, which is impossible for virtually all of them. Another 80% are eligible for premium tax credits, but even with premium tax credits for this population, individual market coverage would cost $250 a month. The essential plan is free, so their health insurance cost would go from $0 to $250. And they would also face enormous deductibles in the multiple thousands of dollars, meaning that even if they did get this coverage, they still likely couldn't go to the doctor or seek treatment without worrying about a financial hit. And those two factors mean that, this group, these folks earn between 200 and 250% of poverty. That's for a single individual, about $35,000 to $40,000 a year. It's just too expensive. And we know it's too expensive because before the essential plan was expanded to cover this group, only about 78,000 people in this income band actually got insurance on the exchange. So if this group loses essential plan coverage, maybe 78,000 of them will find individual market coverage, but the vast majority will become uninsured. There's been a suggestion again, from the executive that, well, maybe they won't get individual market coverage, but they'll get coverage through their employers. This also is unfortunately extremely unlikely. The vast majority of essential plan enrollees don't currently have an offer of employer-sponsored insurance. If you do, you're typically not eligible for the essential plan. They work at small businesses, which aren't required to offer health insurance, as gig workers, freelancers, stuff like that. So in most cases, they actually don't have an offer that they could take up. And employer-sponsored insurance in New York is extremely expensive. It costs about $10,000 a year to insure a single individual. And so, the idea that's sort of being floated by the state that if we let essential plan coverage lapse, then suddenly a bunch of employers in New York State will pay up $10,000 a year to replace that coverage is really, really unlikely. And frankly, even if it were true, the coverage would be vastly more expensive for all concerned and vastly lower quality than the essential plan. So you have the same set of issues that face the individual market. So the question is, what can we do? And, I've been banging the table about this for several months. I released a suggestion back in February about sort of what would an alternative coverage framework look like for these populations. The Community Service Society, in particular, Elizabeth Benjamin and Mia Wagner, released a proposal much more recently that is, frankly, way, way better than mine. And so I'm going to be really focused on talking about their proposal. That proposal is now embodied in legislation that's been introduced in the Senate by Senator Rivera and the Assembly by Assemblymember Paulin. The Senate bill number is S9589. I believe there may not be an Assembly bill number yet. As of yesterday, there wasn't, but there should be one shortly. And this provides really comprehensive coverage and solutions for a range of populations. There are actually 3 different components of the plan addressing different populations. Again, I'm going to be really focused on the essential plan 200 to 250 group in this presentation, just because it's the biggest group by far. But I want to just name check that this bill has 3 components. It addresses immigrants in the Deferred Action for Childhood Arrivals and the PRU-call population who had their coverage stripped by federal changes. That's about 6,000 individuals. And because it's a small group with a lot of, moral authority and significance, right? We have a responsibility to cover these folks, but it's a small group. So covering them would only cost about $21 million in fiscal year 27 and $29 million after that. So this would essentially replace their federal subsidy with state subsidy. Similarly, there's a group of immigrants in the individual market who earn more than 250% of poverty, so they're not eligible for the essential plan. They're currently in the individual market. That's about 15,000 people. HR 1 stripped them of their eligibility for premium tax credits. We could replace their coverage for about $135 million annualized, or $33 million in this fiscal year. And then the big group that I'm going to spend most of my time talking about is the 450,000-ish folks in the Essential Plan 200 to 250 population. the bill would create space for to cover those folks by essentially substituting state money for federal money to keep them on the essential plan. And we're going to talk about this, but there's the question of how much that would cost depends on policy decisions. The best version, which would really cover 100% of these folks, would cost about 1.5 billion in fiscal year 2027. And there's also a lower cost version that would cost significantly less, 339 million. And so I'm going to talk about where those two estimates are coming from and why the variation there. So, um, the short version here of how can we protect the essential plan 200 to 250 population, it's really straightforward. We can just, right now, the essential plan is funded by 100% federal dollars. These folks are being cut off from those federal dollars, but we can just replace that with state money, keep them on the essential plan. They'll have the same high quality free coverage that they have now. Um, and that's a really strong policy option, in part because the essential plan is a great policy tool. So the essential plan delivers healthcare really, really, really efficiently as compared to the individual market, employer-sponsored insurance, whatever else, for basically three reasons. It attracts a very healthy population because costs are very low. Um, Experts on this stuff know that the more you charge for health insurance, the more the folks who enroll in the health insurance are the sicker ones who really need it. And so conversely, if you charge little, or in the essential plan's case, make it free to enroll in health insurance coverage, you attract a big, healthy population, folks who don't need much beyond the annual physical. And that actually keeps costs down for everyone because the population is healthy. The essential plan also regulates provider rates. So unlike in private insurance, where what the health plan pays to hospitals and doctors is the subject to private negotiations between insurance companies and providers. In the essential plan, we regulate the rates, and so we have a lot of control over what providers charge, and therefore how much costs are overall. And then the essential plan has efficient delivery. It's through the New York State of Health. It's straightforward. There's sort of low administrative overhead. Um, and the result of all those factors is that offering someone the essential plan costs between $5,000 and $7,000 a year. We'll talk about that range, depends on provider rates, compared to about $10,000 a year for exchange or employer sponsored plans. So that's really important to think about, is that, you know, some policymakers in New York tend to think like, what's great about the essential plan is that the federal government pays for the whole thing. We don't have to pay for it. And so that's what makes it sort of cheap. But that's not really right. That's not really the case. The essential plan is cheap, sort of regardless of who's paying for it. It costs way less than the individual market and way less than private insurance. Because it's sort of internally efficient. And that what that means is even if the federal government didn't pay for it, it would still be one of the cheapest, most efficient ways to deliver healthcare in New York State. And so for that reason, it's in the state's interest, if we're thinking about how to insure this population, to keep them within the essential plan. To say, even if we could send them to the individual market or to employer-sponsored insurance, for the state as a whole, what's actually the most efficient is just to keep them where they are, because they're already in the best insurance situation. Now, in terms of making decisions about how exactly to keep them on the essential plan, the state has two real sets of decisions that it has to make. It has two key policy variables. One of them is provider rates, and one of them is enrollee premiums. So I'm going to talk about each of those in turn. So the key policy variable around provider rates is I mentioned earlier that the essential plan has regulated, i.e., state set provider rates, meaning that even though the essential plan is administered by private insurers, those private insurers aren't the ones who go and decide what to pay to each doctor in each hospital. The state just tells them what to pay. And historically, the state told them to pay relatively low rates, around 125% of the Medicaid rate. So that's really way, way below what commercial insurance typically pays to providers. The idea was this is a population that's pretty close to the Medicaid population. The Medicaid population, pays 100% of Medicaid, will pay within the essential plan about a little bit more, about 125% of Medicaid. That's how the essential plan worked for almost for the first 8 years of its existence. Recently, just because the essential plan was running so efficiently and there was so much federal money coming into it, there was some extra money. And so the state actually made the decision, as a policy decision, to raise provider rates to around 220% of Medicaid, which raised the cost of offering the essential plan quite a bit. And it raised it from about 5,000 per person per year to about 7,000 per person per year in round numbers. Now, that policy decision made sense when there was a lot of federal money flowing into the essential plan because it was a way to, pay especially safety net hospitals a little bit more at no cost to the state. But now that we're facing these federal cuts and we're having to decide, can we actually afford to continue the essential plan coverage on all for these folks, it makes sense to actually reverse that decision and come back down, at least for this population threatened with disenrollment, to 125% of the Medicaid rate. And that proposal would make it very efficient to cover these folks. And so it's sort of baked into the cost estimates I'm giving. Now, I think some people might say, well, reducing rates for this population, even though it's a small population in the scheme of things, like it might impact safety net hospitals. And so that would be bad. I'm sympathetic to that. But if we don't come up with the money to keep these people covered, then they'll become uninsured. And then, the rate that an uninsured person pays a hospital is zero, right? And that'll be a bigger threat to safety net hospitals. So really, if we're scraping to find money here, we should look at bringing essential plan rates back down to traditional rates. So that's one policy variable. And then the second key policy variable is enrollee premiums. Currently, the essential plan actually is free for enrollees. It doesn't charge a premium. And what that means is that it keeps the enrollee population large and healthy, which is good for the plan. And we have the money to do it currently, so it makes sense. Now, for a population that's this low income, right, $35,000 a year for a single individual, even a modest premium like $50 a month would likely lower enrollment dramatically. And so CSS estimates that enrollment would fall to around 113,000 if we charge this sort of modest premium. It would really decrease enrollment. That obviously would be really bad. The folks who can't afford $50 premiums would be out of insurance. At the same time, because it's so crucial to preserve this program in some form, it may be attractive if the legislature and the executive can't see their way to preserving coverage for everyone, to charge a modest premium reduce enrollment, and that really reduces the cost of the plan because it's a lot cheaper to insure 113,000 people than around 450. So the result of sort of number one, lowering provider rates, and then number two, making a decision about premiums is we kind of have two plans for protecting the essential plan. We could do um, plan A, the better plan, which would have rates at 125% of Medicaid rates and would have a $0 premium that would create an enrollment in this population of around 450,000, around where it is now. And that would cost $1.5 billion in fiscal year 27 because we would only need to cover it for a partial year. And then around $2.1 billion in the out years. So it would have be a new state program costing around $2 billion. That can sound like a lot to people who don't spend all their time thinking about Medicaid, but the simple truth is we run a $120 billion state Medicaid program in the context of a $260 billion state budget, right? And so $2.1 billion to keep 500,000 people on insurance is actually a very reasonable and straightforward way to look. And then, plan B, if we can't see our way to spend the money and sort of do the right thing, which we should do, which is just preserve free essential plan coverage. Plan B would be to charge a $50 premium, also at 125% of Medicaid rates. That would reduce enrollment by a whole bunch, and so it would also reduce costs. In that world, we're looking at costs of 339 million in this fiscal year and under 400 and 475 million thereafter. So just to be clear and direct about what I'm saying here, I'm saying the governor and the legislature should do plan A, but plan B is a fallback we may have to look at if policymakers aren't willing to step up on this. And then the question becomes, right, there are a lot of competing proposals and competing priorities out there. Where do we find the money? In this instance, we're actually in luck on that. We don't need to raise new revenue, tax the rich necessarily to pay for this. Because the state already sort of has a contingency fund it can use for this. So in the executive budget back in February, the governor wasn't sure whether we would get federal essential plan approval. And so the executive budget actually allocates $2.5 billion in fiscal year 27 and $3.5 billion thereafter in case we didn't get essential plan approval. And now that we do have essential plan approval, that pot of money would have been used to cover Aliesa immigrants, a category of immigrants who are currently on the essential plan but would have moved on to state Medicaid if the essential plan had gone away. But thankfully, we did get federal approval. Aliesa immigrants will continue to be covered on the essential plan with federal funds. And what that means is that this reserved 2.5 billion in fiscal year 27 and 3.5 billion thereafter is free and available to cover other contingencies. And in particular, it could indefinitely into the future cover the essential plan 200 to 250 population. So I want to emphasize this point just because, the executive already proposed a budget with $2.5 billion in it for essential plan issues. The executive is not really in a position to go and say, oh, we can't afford $2.5 billion. It's already in the executive budget. We should spend it. We should spend it to avoid this really catastrophic loss of insurance. I want to just sort of zoom out and look toward the future on this proposal because I think the healthcare coverage news has been bleak lately ever since President Trump was elected, ever since the federal reconciliation bill passed over the summer. But I actually think that enacting this proposal would be an important step forward for New York State. Um, a, a, what this proposal would do is it would create a state-funded, publicly regulated insurance vehicle that's independent of the federal government, the vagaries of the federal government's hatred of immigrants, and so forth, right? And that structure of a state-run health insurance program that insures people very efficiently, more efficiently than private insurance, could be a building block on our way to achieving universal coverage through the New York Health Act or through other mechanisms. It could be a really exciting policy tool as we sort of exist in this policy environment where employer-sponsored health insurance premiums are going through the roof, where there are all these other problems. You could imagine a state-funded essential plan version becoming a building block for sort of income graduated uh, premiums being expanded to higher income groups. You could imagine it becoming a vehicle to cover undocumented immigrants in New York, which has long been an advocate priority. And so, the essential plan is, for my money, New York's really best health policy idea. It's unique, it's exciting. This crisis could become an opportunity to really build on it and think about it in a new way. And conversely, letting the essential plan shrink would be a really bad idea. It would be obviously catastrophic for the 450,000 people who are set to lose coverage, but it would also take us back in the direction of the sort of like overpriced, anarchic, burdensome world of private insurance and would erase some of the progress we've made in New York toward universal coverage. It would be for folks who, like many of us, I look to single payer and the New York Health Act as the future. This would be a step back from that. And so, I really think we're at a fork in the road here. And really urge folks to support this bill and to call their legislators, this week or next week and ask them to sign on to S9589 and protect coverage. So I'm just trying to pull up the bill number here because I know people will. Yeah, here we go. So S9589 and check out material from Make the Road and the Community Service Society. I believe they have a call-in tool that you can use to contact your legislator about this. So I'm going to stop sharing there and I'm just going to sort of open it up to questions. I see we have 2 questions already in the chat. Someone asks if they're the only one getting an echo. I really hope not everyone heard an echo during my entire presentation. And then Peter Arno asks this really good question. What happened to the billions of dollars in surplus that the essential plan accumulated over the past few years? So for folks who don't know, the essential plan in its original form before 2024, before it was expanded up to 250% of the federal poverty line, it was like so efficient that we actually were getting more money from the federal government to run the essential plan than it required to run the essential plan. And that money, we weren't allowed to spend that money on anything else. Like it was federal money for the essential plan, so it had to be spent on the essential plan population. We initially used the surplus to just make the essential plan better, to lower premiums, to lower copays, eventually to pay providers more. But finally, we ran out of ways to make the essential plan better than it already was. And the money just accumulated in something called the Basic Health Program Trust Fund. And now there is $10 billion in that Basic Health Program Trust Fund, which is like a bank account in New York State's name that is there. And the challenge in spending that money actually initially was that when we expanded in 2024, when we expanded the essential plan, we moved to a different federal authority and category of program. And so we weren't allowed to spend that accumulated 10 billion on our sort of newly formatted program. So it was just sort of frozen there. But actually, one of the motivations for the state to uh, change its essential plan format and reduce it from 250 to 200 was that actually unfreezes that $10 billion and we'll be able to use that $10 billion to support coverage for the folks who will now still be on the essential plan under 200%. You might reasonably ask, can't we spend that $10 billion to cover these people who are about to lose coverage? Unfortunately, the answer is no, because they're not going to be in the right federal authority for federal regulations to allow us to spend that money. We can only spend that money on the under 200 population. And we will, so it's good. We'll get access to that funding and we'll preserve coverage for folks under 200%. But we do need, unfortunately, a different source of money to fund the over 200% population. What is the overhead percentage on for the essential plan? Susan Beckley asks. Meaning, I assume sort of the administration cost and insurance company profit on it. I don't know the answer to that. You know, the program is quite efficient, but a lot of just generally a lot of the most of the variation in costs between different insured populations has to do with the health status of the insured population, how healthy the group is, and what the provider rates are. So even as you look at insurance overhead, you can ask, that can save you 2 or 3 or 5%. But the big difference between the essential plan and private insurance is that it's a very healthy risk pool and it pays relatively low provider rates. And Susan asks, could we use that 10 billion in trust fund funding to pay providers more for the under 200 population? That's a great question. So one of this is there's a little bit of a complicated thing going on here. So when the state first announced its plan to sort of go back down from 250 to 200 and return to the traditional essential plan, the perception was among healthcare wonks was sort of like, okay, the essential plan will be operating at a big deficit. It'll be really, really challenging to keep it going. But with this $10 billion accumulated surplus, we actually will be able to keep it going for a while. And then we'd better hope that federal policy changes will sort of bail us out. You know, um, Elizabeth Benjamin and Mia Wagner at CSS, their sort of work on the finances of the essential plan shows that is less true than you would think. Actually, the under 200% essential plan is almost self-sustaining. So it isn't like we're going to just fund it for 2 years out of reserves and then it'll go bankrupt. It almost pays for itself and could easily pay for itself with small adjustments to provider rates or with a small investment of state money. And so, that's really encouraging. That it means that we're not headed toward a fiscal cliff. Obviously, we will be strongly advocating if we see a new administration in Washington to just reverse these cuts and sort of go back to the original finance formula. Hmm. Um, Elizabeth Benjamin weighs in as the expert here to say that essential plan overhead is about 6%, which is quite low. That compares very favorably to employer-sponsored insurance. Um, wow. A legend is among us. Former Assemblymember Dick Gottfried, someone I'm a big fan of, and many on this call I'm sure are as well, asks whether the handling of claims under the Essential Plan is done by insurance companies or by state employees. And the answer is the Essential Plan is it's administered by insurance companies. So it's very much like Medicaid and the individual market in New York. You go on New York State of Health and you enter your information. And if you're eligible for the essential plan, you get a choice between the essential plan offered by Metro Plus, the essential plan offered by, Fidelis, right? Like you're choosing among private insurance companies that the state contracts with, and then they administer the benefit. But you know, unlike with private insurance, the state has a much, much stronger role in regulating what benefit you get, what the appeals process is, what the provider rates are, and what the costs are. So it is, I'm a big advocate for the government just doing stuff directly itself, but I'm a fan of but I'm a fan of, like, on that spectrum, the essential plan is much more public than the individual market or than employer sponsored insurance. Mm. Um, Someone asks, Susan asks, can the feds claw back the 10 billion, which they have done with other federal funds? The answer is no. It's our money. It's in a New York State trust fund. We have a right to it, and we have legally binding agreements with the feds that entitle us to it. And also, if they had wanted to claw back those funds, they wouldn't have approved our new essential plan model, which they did. So we're in strong situation there. Um, Someone asks if the essential plan covers long-term care. The answer there is traditionally it didn't. A couple of years ago, it was expanded to cover long-term care. But unfortunately, now that there's less money available for it because of federal cuts, they've reversed that and it's not going to cover long-term care. I think the long-term care coverage was not ever actually implemented. And so it's sort of like we were going to do something, but now we've decided not to do it. But yeah, the answer is no. Someone's asking, can we unlock the 10 billion? The answer is yes, we unlocked the 10 billion when we got federal approval in late March. That federal approval allowed us to move back to the old essential plan. We can use the $10 billion trust fund to support the essential plan population that's under 200% of the federal poverty line. So the group that is going to be protected as of now, we can't use that $10 billion to cover folks above 200% of the poverty line. So that's why we need this really important bill, and why CSS and Make the Road are doing such a great job campaigning on it. Whew. Um, let's see. Uh, Ashley asks, are essential plan beneficiaries subject to the Medicaid work requirements? And the answer is no. The essential plan is not a Medicaid program, and it's not really funded with federal Medicaid dollars. It's actually funded with federal ACA premium tax credit dollars. So it's in a sort of separate category there. Bernadette asks if I can talk about my original proposal from before this bill and CSS's proposal, and why I think that why I think the CSS proposal is better. So what I had originally proposed was that this essential plan 200, 250 population that's about to lose essential plan coverage, they could go on to the individual market. And, the problem there would be that the individual market would be expensive for everyone. Even if they qualified for premium tax credits, it would cost about $250 a month. And then for the 20% of this population that are lawfully present immigrants and aren't eligible for PTC, it would be really, really expensive, or, totally out of reach because they would have to pay, $10,000 a year out of pocket. And so what I thought though was like, okay, you know, the these folks would be eligible for some federal subsidy, and then the state could just layer on top of that federal subsidy, it could layer state subsidy. So, like, the federal government would pay a lot of the cost for many of the enrollees, and we would pay what was left, essentially. And um, that would have been still quite expensive because in New York, individual market coverage is really expensive, much, much more so, like almost twice as expensive as the essential plan. And so it would have been really expensive, even though the federal government would have been picking up part of the tab. And the bigger issue was that would have been that the individual market insurance would have had really, really high deductibles and copays. And, for me, like, I'm lucky enough to be paid a decent salary to noodle about healthcare at the Fiscal Policy Institute. And so for me, if I have a $2,000, $3,000, $5,000 deductible, it hurts to get healthcare, but it's not like a binding obstacle. I can pay that if I need to. For this population, having such high deductibles and copays is really, it's not that much better than being uninsured. You still can't comfortably go to the doctor. And so, getting people insurance that was um, as inadequate as that would not have been nearly as much of a win. And it would also have put folks in a much less efficient, much less public insurance giving vehicle. So, so I sort of came around to the view pretty quickly that what made more sense was actually don't pay a lot of money, over $1 billion a year, to put people in this bad insurance vehicle of the individual market. We have something that works for them. Let's just keep the thing that works. So I hope that's helpful. Hmm. All right. I think people might be running low on questions. So if folks want to if folks want, if unless there's anything else, I would just say I am, I would just say, I'm really, really appreciative that we have leaders on healthcare policy like Senator Rivera and Assemblymember Paulin, who are the chairs of the health committees in their respective houses. Because this is an issue that was really not getting the attention that it sort of deserved and needed, regarding this stuff. So really want to appreciate them, and then really, really want to ask folks to call their assembly members and senators and just say, this is something I'm watching in the budget. Have you co-sponsored these bills? Because it's a really incredibly, incredibly crucial issue. I think from my perspective, this is the one do or die thing in state budget negotiations this year. So um uh yeah. So really appreciate, I think someone had their hand up. Really appreciate this. We will I'm digging around for the Healthcare for All New York Make the Road CSS sort of call-in tool that can help you call your legislator. I will send that out with the follow-up email with slides and recording for this. Yeah, so be on the lookout for that. All right. Uh and Mark Honey, who's done amazing work for around this at Healthcare for All New York, just really emphasizes we need everyone to be a co-sponsor on this bill so that it actually gets done in the budget. You know, the budget is delayed and people are sniping at each other in a way that makes it seem like we might have another week or a couple of weeks to organize around this, and that's great. So just please remind people of how important it is to co-sponsor. Thank you all so much for coming, and I will send out slides in the recording, and please don't hesitate to shoot me an email at Kinnucan@fiscalpolicy.org if you have any other questions or thoughts. Have a great weekend, everyone. Bye.